This is the 9-month-old infant, progressive abnormal enlargement of head from 3rd month after birth, admitted with vomiting and lethargy, discuss the management. So here you have to make a diagnosis because it is not overtly given that is the case of hydrocephalus. So progressive abnormal increase in head size, possibility of hydrocephalus, vomiting and lethargy, possibility of raised ICP. So it requires immediate attention. It is like a quasi-emergency surgery intervention is required. So what could be the etiology? It could be congenital like Arnold Chiari or acquired like brain tumors or intraventricular hemorrhage. So even if they ask you whether it could be brain tumor, you can say yes, because in brain tumor also the pressure will increase, and that could be the reason for the lethargy and loss of vomiting and all these conditions. And there also the ICP will raise. So you can say it could be a possibility, it could be hemorrhage or brain tumor also, sir. And why it takes almost 6 months to exhibit these features of raised ICP? Because infant skull is more compliant, slowly expands in response to gradual increases in ICP, and it offers a great deal of resistance to acute increase in ICP by these measures. And normal value of ICP, infant ICP must be as low as 2 to 4 millimeters of mercury compared to the adult ranges of 8 to 15, because the adult skull is a rigid box. There the pressure will always be higher, whereas this much of more than 4 millimeter itself is high for a infant, because it should be a very compliant skull. And what are the effects of various blood pressure on infant or cerebral blood flow? And they are at a risk of ischemia when mean arterial pressure is low, whereas systemic hypertension may result in intraventricular hemorrhage in the infant. So their mean arterial pressure is very, if it is low, that will result definitely in cerebral ischemia. And cerebral perfusion pressure is by definition, is the difference between the mean arterial pressure and the intracranial pressure and central venous pressure. And here central venous pressure is taken as 0. So normally we calculate it by NAP minus ICP. And the Cushing's triad is nothing but systemic response to increase the blood flow. When the ICP rises, the systemic blood pressure increases. So it results in systemic hypertension, which will reflexively cause a reduction in the heart rate. That is a bradycardia will happen. And at ICP more than 20 millimeters, there will be focal ischemia, and more than 50 millimeters, it will be global ischemia in an adult. Whereas in children, between 5 and 10, it will be focal ischemia, and more than 10, it will be global ischemia. And coning is an important, very dangerous complication of any raised ICP, where cerebral contents go through the foramen magnum, and this can lead to ischemia of the cardiac and respiratory centers situated in the brainstem, resulting in cardiorespiratory arrest and death. And any rise in ICP can cause this coning. And shunt procedures are usually done to reduce the pressure inside the cranial cavity by diverting the CSF to other locations, like wherever it can be absorbed, like the peritoneum, atria, or pleural cavity. And there is a procedure which was very popular in the early stage of this century called the endoscopic third ventriculostomy, where a hole is made in the third ventricle, and the fluid is, the CSF is allowed to drain directly into the subarachnoid space of the skull and go into the vertebral canal. And so this is the procedure where they use a neuroendoscope to facilitate the CSF drainage. But initially, later on, it was abandoned because of a lot of complications. But with the improvement in the availability of instruments and anesthesia, this endoscopic third ventriculostomy is finding an alternate to the regular VT or aviation which is being performed. And features of this hydrocephalus are bulging fontanelle, dilated scaphoids, and separation of sutures. So you can see all these things happening in this particular condition. And McEwen sign may be asked. It is nothing but a cracked spot sound. By when you percuss the skull, you will find the sound coming, or the feeling will be there. That is called the McEwen sign. The sunset sign is it's an ophthalmic feature occurring in the eyes of a hydrocephalic child, where the eyes look down and the pupil, lower border of the pupil is covered by the lower eyelid. Okay, so it always looks like the child is looking downwards at the feet, and this is the sunset sign because of the increase in the intracranial pressure. And the relationship between the head size and the chest circumference in a newborn is the chest is always smaller than the head. So the side will be bigger. And the average head circumference at birth, this is the value. At 0 months, it's about 34 to 36. And gradually increases by 1.5 centimeters. And at 3 years, it stops growing further. It becomes 48.6. And then gradually increases very slowly. And the hydrocephalus can be classified based on the age of the patient, whether it is pediatric or juvenile, and clinically whether it is high pressure, which is acute or chronic, or normal pressure hydrocephalus. And what are the features of normal pressure hydrocephalus?
There will be gait disturbance and urinary incontinence and dementia, sir.
So what is all these three put together? What is the name for that?
Hutchins and Adams triad.
Triad. Yeah, very good. It's called Hutchins triad. And pathologically, it can be congenital or acquired. Functionally, it can be communicating and non-communicating. The history to be elicited are problems with the usual standard history of family history, any previous anesthetic, past medical history, current medication, etc. And last oral intake if the patient is taken up as a quasi-emergency. And comorbidities, especially congenital cardiac disease, more than cleft lip and cleft palate. This may be associated with congenital VSD or AMD. Respiratory problems like bronchopulmonary dysplasia or kyphoscoliosis may be present. And important clinical examination, we have to assess the airway, cardiorespiratory and neurological system, and volume status, because the history is given the child is having vomiting. The child may be hypovolemic and hypotensive, which will aggravate the ischemia of the cerebral system. So volume status has to be assessed. And investigations, we can do blood tests to assess the hemoglobin and clotting factors, urea electrolytes to find out whether there is preliminary uremia, and a CT scan to find out this what is called the Evans ratio, where you find the frontal horn distance with the interparietal distance. If it is less than 40, it is normal. 40 to 50 is considered as a borderline. More than 50 is definitely hydrocephalus. And very rarely MRI may be needed. And if this is the investigation you mentioned about, sometimes they may ask you, how will you give anesthesia for MRI for this child? Supposing neurosurgeon wants an MRI of this baby, how do you anesthetize the child for MRI? Can you give ketamine?
No, sir, I will avoid ketamine.
You have to just give minimal sedation, because that will also worsen the condition.
Worsen the neurological status.
So this is a very great challenge. If you want to do an MRI in a child with raised ICP, it should be almost like dealing with the management for any interventional procedure like that. Okay, so it cannot be lightly taken. Like you cannot give ketamine, midazolam as you please, as you give it for other normal babies, where you do it for MRI scanning. So it could be A regular induction, intubation, and maintenance with controlled ventilation may be needed in these children, even for MRI also. And what is the treatment available? You can classify into drug therapy like acetazolamide. So acetazolamide prevents the formation of CSF, and gradually the dose has to be increased, and we can give furosemide diuretic to reduce the volume. But if the patient already has vomiting and dehydration, furosemide cannot be continued if already it has been started. And to treat acidosis, which could have happened, sometimes they may need what is called tricitrate 4 ml. That's a liquid which can give to correct the acidosis. And very rarely you may need to do a spinal tap to remove the CSF, and in communicating ICP it will be useful. So you can remove the CSF. Otherwise, surgical therapy can directly interfere with the formation by doing a plexotomy at the choroid plexus, which is a more invasive thing, which is not commonly done. And as I said, third ventriculostomy is the other invasive option. But the shunts are very simple and very useful method commonly performed. And the anesthetic management will be, the challenges are challenges of pediatric anesthesia, especially the infant anesthesia. So this part is the one which you have to remember for answering a short case scenario. So the challenges will be specific pediatric anesthesia problem, and because of the large death, you may have difficult airway due to large death, and problems due to ICP and its management. So this is how you must classify the challenges in this management. You can straight away go to the discussion on how do you manage this case. You can classify like this, and then pre-op optimization, signs of any neurological dissociation should be observed. You can use topical EMLA cream to secure an IV access to prevent the child from crying, and which may cause a rise in ICP. You can correct any hypovolemia and electrolyte imbalance according to the blood test. And for that, you can use normal saline or lactate, and use with a warmer to maintain the body temperature. And adequate antibiotic coverage should be given. And check all the anesthetic equipment, drugs, and make sure they are all in working order before moving the baby into the theater. Check the breathing system that you are going to use, the face mask, oropharyngeal airway, tracheal tubes, etc. And a good working suction and tilting table are important. And if there is an anticipated difficult airway, plan for positioning the infant and have the help of an experienced person, so that there will not be any calamity because of the failure to secure the airway. And standard monitors are sufficient, and don't forget to include temperature in all pediatric cases. And the method of induction of anesthesia, with the patient in the supine position, head tilted to the opposite side of the shunt that you are going to perform with a slight head up tilt. The intravenous induction will be the best method if you have already secured an IV access. In cases where there is a difficulty in securing IV access, gaseous induction also has been performed. But you must remember that all volatile anesthetic agents, they increase the blood flow and increase the ICP in a dose dependent manner. So gaseous induction can be avoided as much as possible, unless you have no IV access and you want to induce and then secure the IV access after reduction. That is the last option that you have to remember. And anesthesia is maintained by very one max dose of volatile agent with a mixture of air and oxygen, and controlled ventilation. You can maintain CPP until the raised ICP is relieved. Hypotension should be avoided at any cost. Maintain normocarbia, don't hyperventilate and reduce the VO2. Earlier it was done as a method of reducing the ICP, but it resulted in more cerebral ischemia and decreased the blood supply. So it is not recommended anymore. And maintain normothermia. And if you are using PEEP through a pediatric ventilator, PEEP should be minimized as much as possible to avoid venous congestion in the scalp and inside the pregnant. And ondansetron can be given to relieve post-op vomiting. And analgesic, you can use fentanyl or remifentanil infusion. And paracetamol can be given both by intravenous route as well as a suppository. And the infiltration of the incision site as well as the tunneling site with butyrothane is routinely done to avoid too much of requirement of narcotic or other analgesic agents. And after completion of the surgery, patient can be allowed to resume spontaneous respiration, and then any neuromuscular residual activity can be reversed using neostigmine 40 mg per kg and glycopyrrolate 20 mg per kg. Trachea aspirated after adequate ventilation, and you must record the conscious status before induction, and there should be some improvement in the conscious state. If the patient has been lethargic, there should be some brisk activity once the pressure has been released. So it is very important to note the sensorium before and after surgery so that you know whether it is improved or you have not achieved sufficient drainage and reduction in pressure. And post-operatively, they should be nursed in the post-anesthetic care unit with the head up tilt and chin lift, and no airway obstruction should happen, which will cause hypoxia and hypercarbia. And the shunt should be monitored to see whether it is draining properly so that the reduction in ICP is maintained. And sometimes large hydrocephalus, when they are drained, there may be a rapid shift in the fluid status, and that may cause a sudden collapse of the ventricle and cause more problem. And to maintain adequate perfusion of the cerebral tissues, you must maintain isovolemia with isoosmolarity, and isooncotic fluid or blood fluid should be given. Infuse only warm fluid so that normothermia is maintained, and child should be adequately covered, and the core temperature should be maintained. Sometimes there may be complications because of the VP shunt, which may be like bleeding from the wound, intracranial hemorrhage, collapse of ventricle, and pneumothorax when you try to put it into the pleural cavity, or infection, or shunt obstruction, or misplacement of the shunt. And when you try to put it into peritoneal cavity, double perforation, all these things are complications. Now, management of difficult airway, just for those who have not seen, if it is a case like this, how it is to be managed. Keep two folded blankets below the body of the baby, like this. Okay? And then allow the head to hang and touch the table like this, so that the airway will open and you can mask ventilate, and you can use of a VDL laryngoscope will be more useful. Nowadays, they are all available, and instead of using the conventional regular laryngoscope, if you have VDL laryngoscope and you use it, it will be easy to achieve. Sometimes in such cases, we may be putting the patient in lateral position and intubating also. So lateral position with a regular laryngoscope also sometimes may be done. That will also successfully achieve the intubation. And of course, older children can do total intravenous anesthesia with infusion of propofol and remifentanil till the drainage is done, and then slowly taper it off. And of course, this is the thing that we have to remember for hydrocephalus. All these points that we have to remember. Okay.